All right, good afternoon, everyone, and welcome to FWMD Live. And today we're talking about COVID-19 and what we have learned about the coronavirus since the first case was reported in the United States back in January. Now, I'm your host, Prescott Stokes III, the Integrated Content and Marketing Manager here at the TCU and UNT HSC School of Medicine. And today I am happy to be here with Dr. Joanna Luke.
Thanks for having me, Prescott.
All right. Thank you, Dr. Luke. I just want to let everyone know that Dr. Luke is an emergency medicine physician at Texas Health Fort Worth, and she is also the Assistant Dean of Curriculum here at the School of Medicine. I am also happy to have with us Dr. Kareem Jamal.
Hi, everyone.
All right. Thank you, Dr. Jamal. And I just want to let everyone know that Dr. Jamal is an emergency medicine physician at Texas Health Harris Methodist Hospital in Fort Worth, and he is also an assistant professor here at the School of Medicine. Now, our experts will be answering any questions you have about COVID-19 and also the flu. It is flu season. It began on October 1st. So all you need to do to be a part of this conversation is jump into the comments, leave your question, and then I will definitely get you some answers. But before we get to your questions, I am going to begin with Dr. Jamal. So as of October 7th, there have been 7.4 million reported cases of COVID-19 in the US and 210,000 deaths due to COVID-19. So Dr. Jamal, you were here with us back in March when everything kind of first started to happen for a lot of us, and we started to have to social distance and go into lockdown and things like that. So what else have we learned about COVID-19 and how it spreads between people since then?
Wow. So Prescott, 7 months ago was like a lifetime with this illness. I remember being in your studio without a mask, and things are very different. So specifically about transmission, I'd say that there are three main things that we have learned that are very important. The very first thing is that we felt that the people that were symptomatic, the people that had the cough, were people that were more likely to spread the virus. In fact, it's the pre-symptomatic people or the asymptomatic people that are more likely to spread the virus. So really, no one needs to have a cough to be able to spread it. That's really a very important thing that we've determined. The second is that we thought that as long as you stayed 6 feet away from someone, that how this virus was spread was through droplets. And now we know that it's spread both by droplets and by aerosols. So really, little itty bitty particles, less than 5 microns, can infect someone. So now it's not just that they have to be within 6 feet, they could be more than 6 feet. And the CDC recently changed this last week, that a room can be infectious without anyone in it. The last thing is that how the infection is actually spread among people. This idea about super spreading events have gotten our attention, and what we now know is that there's this thing called over dispersion, and that how the transmission is spread is it's spread heterogeneously and not homogeneously, and that it's spread in clusters and communities. So in these three areas, the virus has that we've learned a lot about this virus. So I think all of this affects how we prevent from getting it.
And so actually, since we're talking about preventing yourself from getting it, has any of the guidelines on the best way to protect yourself from COVID-19 changed since March?
I'd say there's some generalities that are the same, but I think the stresses are different. So the generalities that are the same is, there are things that you have to avoid, and then there are things that you have to do. The things that you have to avoid have been pretty much the same things. You have to avoid the 3 C's. The 3 C's are confined spaces, crowds, and any close contacts. So you still should stay more than 6 feet away from people, but really confined spaces, crowds, and close contacts. And the things you need to avoid, again, they're the same, but I'd say that now there's an extra stress on masks. On February 29th, you said March. On February 29th, there was a tweet by the Surgeon General saying that we shouldn't use masks. So there's been a dramatic change about that. We now know that masks are very important. The things you need to do that haven't changed is you still have to wash your hands. You still have to keep your hands away from your face. You still have to, you have to wear a mask, and you have to clean contaminated surfaces if you're around someone that has the virus. So I think there are some differences.
All right, so that's some good information, just understanding how things have evolved a little bit about what we know about COVID-19 and also how to protect yourself from COVID-19. A mask has become very, very important, as Dr. Jamal just said. And for anyone who is just joining us on Facebook, today on FWMD Live, we're talking about COVID-19 and the current flu season that we're in and what we've learned about COVID-19 and also what we need to know about having COVID-19 and the flu season happening at the same time. Dr. Jamal is with me, Dr. Luke is with me, so if you have a question about it, jump into the comments, leave your question, and then I will definitely get you some answers. So Dr. Luke, for patients who are symptomatic, what are some of the things that they are telling physicians now that they're experiencing from COVID-19 that might have been different from March?
So thanks, Prescott. Back in March, we were really focused on, you need to be concerned if you have a high fever. You need to be concerned if you have a cough. You need to be concerned if you're short of breath. I think, to Dr. Jamal's point, what we realized is really there's a longer list of symptoms. And so some things that I've seen personally in my practice is that patients also have a lot of fatigue. They complain often of muscle aches, headaches. They even can complain of GI symptoms, so nausea, vomiting, diarrhea. These were things that we were maybe not as attuned to at the very beginning of this virus. The other thing, while not as common, is that patients complain of a loss of taste or a loss, especially of smell, seems very particular to COVID. So other viruses can cause those, but a lot of times the first symptom that a patient notices is that they can't taste their food or they can't smell things in their surroundings. And then just as a reminder, again, Dr. Jamal brought it up, but it's so important. Even if you have no symptoms, but you've had a close contact, and we're defining that as 15 minutes or more within 6 feet of somebody that knows that they have COVID, you also need to reach out and get tested.
Interesting. That is really good information within 15 minutes. And now there's a time frame. I remember before there weren't any sort of time frames because we're still learning everything about it. It's really new. So understanding that 15-minute time frame, if you've been around someone who has COVID-19, you might actually need to get tested. So that's really good information, Dr. Luke. We did have a question from Facebook. Thank you all for leaving your questions. Just jump in the comments and leave your question and we will get some answers. So the first question is, with confined spaces being a concern, what would your opinion be in regards to kids going back to school in person? My children are back in person and wearing masks all day. Dr. Jamal, would you have any advice on those confined spaces as far as some young children in schools?
So we know that this virus affects the elderly disproportionately more than it affects the youth and especially children. There are some syndromes. There's one particular syndrome that's gotten lots of attention, but it's generally the general rule is that it doesn't infect children the same. I think this is it is. There's a lot of unknown about what's going on with reintroducing students back into the classroom in confined spaces. I could see where administrators are trying to thread the needle here, but I can say that I couldn't give you a definitive answer whether somebody ought to do it or not do it. I think this needs to be done with a decision with the family and with all the data that's out there. So there's an incomplete database on this. This is the first time kids are going back to the classroom. Up until now, we've not allowed that. So I think that monitoring will be very important.
And Dr. Luke, I just also want you to just chime in on that a little bit as well. As a physician, as a parent, when you think about these confined spaces, do you think parents should just be a little more vigilant as far as like making sure their children understand the importance of wearing a mask?
Yeah, I think that's a great plan. So I want to make sure to say two things. One is that every family, right, has to make their own decision and has different factors that come into play, right, depending on if people in the family have comorbidities or other illnesses that might make them at higher risk. And so every family has to make the decision that's right for them and safest for them. And then the second thing I want to say is just a huge shout out and thank you to our teachers, to our school administrators. Everyone's working really closely with the Department of Public Health and following those guidelines that we've been given through the CDC. And so teachers are already doing an amazing hard job, and now even more so. But they are doing their best, right, to keep the kids in their masks, to keep them separated, to wash their hands. And so as parents, we just need to support that. And I think the kids do better often than adults. I have to remind mine that they can take their mask off when they come in the house after having it on when they've played outside. So I think kids are more resilient than we give them credit for. And again, a huge thank you to the teachers. You really are our hero.
All right. And so today we're having a chat about what we know more about COVID-19 and also the flu season, because it's happening simultaneously right now. So I have Dr. Luke, an emergency medicine physician at Texas Health, also Dr. Jamal, another emergency medicine physician at Texas Health, just giving us some updates on COVID-19 and what we know so far and what you need to know about the upcoming flu season as well. If you have questions, jump in the comments, leave your question, and then I will definitely get you some answers. Dr. Luke, I want to switch gears a little bit and talk about testing for COVID-19. In the beginning, there was so many images of people on social media talking about getting the swab up the nose and how it feels and all of those things about getting tested. Has any of that changed so far with COVID-19 testing?
Yeah, so I think this is one of, the most kind of complex and confusing topics because there are so many kinds of tests. And, when we talked last time, there was just a huge concern that there weren't enough tests. I think we're in a much better spot now that it's much easier to access testing. But just in general, when I think about testing for COVID, I think of kind of two big buckets. So one big bucket is diagnostic testing, meaning tests that tell you, do you have COVID right now? And then the other bucket is antibody testing, meaning have you had COVID recently? And so I'll leave that for a little bit later, but thinking about that diagnostic testing, there's really kind of two types. So one type is molecular testing. So this is looking to see in your body, is there the virus's genetic material? Sometimes, an example of this would be a PCR test. These are usually with the nasal swab, and they can take a little longer for the results to come back. And so it may be, 24 hours or even a couple days to get your results back from this type of testing. And the other type of testing looks more for kind of proteins on the surface of the virus. And so this is testing that can be done more rapidly. Often you get your results back, in 15 to 30 minutes. And again, both of these testing, they're looking for the virus, usually with either a nasal swab or a saliva sample.
Okay. And Dr. Luke, with those two tests, the one where you get the quicker result versus the one where you get the longer result, should residents be concerned about the accuracy if they're trying to figure out, I really want to know if I have it, right? Is it in their best interest to take the longer test and wait for those results, or is it the shorter test, or does it depend on their health circumstances when they arrive?
Yeah, I would say that it's really multifactorial, but really either test can miss the virus if it's too early. And so if you are currently, symptomatic, or if you know that you were exposed, a number of days before, probably either test would be fine. Though both certainly can have false negatives. And it is true, there are more false negatives with that more rapid testing. But if you have a high enough viral load, either should be able to pick that up.
All right. Thank you for that information. Now I want to switch gears a little bit and talk about the flu. So we have COVID-19 happening, but we have the flu season that began on October 1st. It's normal. It happens every year. We all know about flu season. We want everybody to make sure you get your flu shot, get vaccinated. On September 29th, the Star Telegram reported that there was one case of a dual report of COVID-19 and the flu in one person in Tarrant County. So as we know more about COVID-19 and know more about the flu, Dr. Jamal, can you just tell us some of the differences between COVID-19 and the flu if someone is trying to figure out which one they might have?
Yeah, so when both these are viruses and they both start off with a viremic phase. So initially it's very difficult to tell. They both have fever, they both have myalgias, arthralgias. The flu has a lot more upper respiratory type symptoms. So they'll have what we call coryza, where they'll have a runny nose and more of a sore throat. That's less common in COVID-19. COVID-19 will have more of a cough. They both can have GI symptoms, but there's so much overlap. I think Dr. Luke mentioned about anosmia and dysgeusia, which are two fancy terms for the loss of smell and the loss of taste. So those are more specific for COVID-19 than the flu are. There's lots of overlap. It's hard to tell the difference. I think that that's what's made people a little bit concerned that once we get into the flu season and we start to see a lot more flu, that these two diseases will be difficult to detect because they're so similar initially. I think that with us using our masks more and doing the social distancing and washing our hands, I think we're hoping a less strenuous flu season.
And Dr. Jamal, I guess, can you talk just a little bit about the idea of wearing masks and it kind of may be reducing our flu numbers across the country because so many people are wearing masks? It seems as if masks are really, really important as far as the spread of viruses, especially ones like COVID-19 and the flu, right?
Yeah, no, I can't stress that more than more really. So, people have done this, they've done lots of studies on the use of masks. There's a really, really nice study that was done in Germany that showed that once they started mandating masks, they decreased the daily positivity rate of COVID by 60%. And this is surgical masks. And so, these are respiratory pathogens we're talking about, both of them, and they're spread from people to people. So it's the use of masks. Really, it really has to get to a point to where when you leave your house or apartment, you should feel almost naked if you don't have a mask on.
Right, and that would help everybody, right? So we understand the importance of masks. Dr. Luke, you work in the emergency room. Just so far since the end of September, early October that we're in right now, have you seen any cases of anyone coming in with flu-like symptoms and they already have COVID or vice versa?
So I personally haven't had any patients yet that actively have both a positive COVID test and a positive flu test. But every shift, I'm definitely seeing patients with positive COVID tests. And then now we are just starting to see kind of that uptick of flu as well. So it's in our community. And really we would just, implore you, get the flu shot this year. It's more important than ever. To really help you not to have to come see me, to not have to come to the hospital. And then, as stated, all the things that work to help you not get COVID work to help you not get the flu.
All right. And Dr. Luke is great, by the way. So if you needed to see her, she's fantastic. But
come see me if you need me, but we would for you not to have to come see me.
Yes. So we're having a conversation about COVID-19 and also the flu season. Both of these things are happening combined right now across our country, across the world. If you have any questions about it, I've got Dr. Luke and Dr. Jamal here. Jump in the comments, leave your question, and then I will definitely get you some answers. So we do have one question about the flu shot that came in. And so thank you for your question, first of all. And the question is, when is it recommended to get the flu shot? And the person also said, I was recently told to wait to get vaccinated because of the window of effectiveness of the vaccine and the height of the flu season being later in the season. So this is something I have also heard myself, and I heard people talk about, maybe I'll wait to get my flu shot in November so it can last me a little bit longer versus October. Is there any logic or rationale behind when you should get the flu shot?
I think that's been talked about more this year because as physicians, we almost immediately, even in March, we're looking ahead to what are we going to do when we have both COVID and flu. And so I think there was a lot more talk early about the flu shot, and so maybe that's where some of the concern came. So certainly we wouldn't have recommended you to get it in the summer, but now, as you mentioned, Prescott, we're in flu season, so the time is now to get your flu shot.
All right. Great information. I want to move on, but also move a little bit backwards to something you mentioned earlier, Dr. Luke. So you mentioned antibody testing. And I just want to know if you can kind of explain to us, what do we know about antibody testing and its effectiveness as far as people thinking that they may not be able to get reinfected with COVID-19 if their body builds up the antibodies for it?
Sure, that's a great question. And I think the first thing that we all need to say is that we don't know yet, right? Like this is one of those areas that really has a lot of just continued research and development. So I'll start by just making sure everyone knows what we're talking about with the antibody test. So this is a test that actually would be done looking at your blood, so instead of the nasal swab. And it's looking to see, has your body produced that immune response or that protective response and would demonstrate that you've had COVID. So this test is not for, do I have COVID right now? This test is for, have I had COVID recently? But what we don't know is how many antibodies do you need to be protected, or how long do those antibodies last? Or even, is COVID going to change to where that protection that you had doesn't work the second time around? I will say there's absolutely been reports now of patients that have been reinfected. And concerning, there was even a report out of Las Vegas, a patient that the second time around had a worse disease. And so I think we can say with fair authority that just having COVID does not mean you're forever immune to COVID, but there still are a lot of questions. So I would say, even if you've had it, don't let your guard down because we just don't know yet.
And Dr. Jamal, I just also want to give you a chance to chime in on that. And just what we know about being infected a second time. Like we all know that if you get the flu, you can get the flu again, right? And with COVID, we're learning, but we are seeing that if you get COVID one time, there's a possibility you could get it again. And what we don't know is, like Dr. Luke said, will it be more or less severe, right?
Yeah. So the first part was, about the antibody tests in general. So, you just have to look at the FDA website and you'll see that there are 47 tests that have been authorized for emergency use authorization, 47 separate tests. And so there's so much variability in these tests, and it's really, and what it means is when they've given an EUA, an emergency use authorization, is that the company gives the data to the FDA and they don't have enough time to double check all the data and do the tests individually. So there's a lot of variability in these tests. If the test is good, if it's a valid test, and there's an if there, then the test is very, very helpful. It has great sensitivity. That we're talking about the antibody test is great sensitivity and also great specificity. It can be used in the acute setting when a patient is negative for the PCR test or the antigen test. Those tests generally wane. The PCR and the antigen tests generally wane in the first 7 days. And then after that, in like day 6 or day 7, the antibodies start to come up and then they peak at about day 14. So there are times when the antigen test and the PCR test will be negative and the antibody test will be positive and the patient will be sick because they're now in the immune phase of the infection. So it's helpful in the individual case. Of course, the antibody test is hugely important for public health and for us to sort out what the seroprevalence is of a disease in communities, and it'll give us an idea of which communities are more at risk and where this disease is likely to go next. So, once we get past the variability of the test, I think that the test is very helpful. About whether you can get reinfected, there are cases, as Dr. Luke said, the one in Las Vegas. But I just want to say that there's been a study, there was an excellent study by the CDC Korea, and I'm trying to look for it here, but basically what they came They looked at about 285 people that had the disease and were tested negative. And then they found these 285 people that then tested positive after a period of being testing negative and being sent home. And those 285 people that were positive, although they were positive, the virus could not be cultured from their nasopharynx. It was just the PCR. Also, they looked at the contacts, the close contacts of those people, and they found about 700 people that were close contacts, and of the 700 people, 3 of them ended up getting COVID, but they probably got that from another known contact. So what the general feeling is that that maybe there is a reinfection rate, but my feeling is, and again, this is all about, there's a lot of data still that's going to become available. My feeling is it's not going to be a big problem. I think that mostly once you're infected, you're not going to get reinfected again.
All right, that's very good information, Dr. Jamal. So if you're just joining our live chat, this is FWMD Live, and today we are talking about what we know now, 7 months later, about COVID-19, and also about the flu season and having them happening at the same time right now. If you have any questions, jump in the comments, leave your question, and I will definitely get you some answers. We did have one question that came in. And this question, thank you for your question first. And the question is, I saw an article that said that this virus is mutating and mask and hand washing are not as effective as they were in the early days. What does this really mean? Dr. Jamal, from everything that you've read and a lot of the studies that you've read, has wearing a mask or hand washing become less effective than it was 7 months ago?
So I think we need to separate the idea about whether it's mutating and how it's changed the virus. And then the second part is, what can we do to still prevent getting it? So it has mutated, and it's not the same virus as was in Italy. It seems to be more infectious and less lethal. Again, this is, again, some conjecture to that. But in general, it seems to be more infectious. However, still, washing hands and masks are now even more important, I'd say, that if something's becoming more infectious, this is a respiratory pathogen. It's spread from person to person. The basic biology of how that droplet gets into your nasal passages from someone else's, that hasn't changed. So I would say that, I would wash my hands more. I would wear my mask more often. I think it would make the argument that we need to do those more vigilantly.
All right. Actually, I want to talk a little bit about treatment. So Dr. Luke, working in the emergency room, when we talked in April, you talked to us a lot about what you all could offer to patients who had severe symptoms. And a lot of it was people were talking about the respirators and needing help breathing. Have you seen any other new treatments for COVID-19 patients that might be a little bit more effective now?
Yeah, thanks, Prescott. So this is another area where, we've had so much change since March. So when we were first starting, we were very quick to intubate patients. And so that's what you hear talking about, us putting a breathing tube in, and then that patient would be on a ventilator. So basically a machine breathing for them. We realized that there were likely some other ways, including even positioning the patients kind of on their stomach instead of their back, that could help prevent them from needing to be intubated. And so we are now intubating much fewer patients, which is good news for patients and for the ICU, levels and ventilator levels. Unfortunately, we still have no treatments if you're in that mild disease category or moderate that does not need to be admitted to the hospital. So still for that group, no known treatments that work. It's really monitoring that you need to do to make sure, that you come back if your symptoms get worse. For the group that actually gets admitted to the hospital and needs oxygen, the most promising trial has been around the steroid dexamethasone. And so again, that really is been shown to help patients that have an oxygen requirement. We're also giving ritonavir, so an antiviral, again, really has been shown, to have benefit for patients that are having an oxygen requirement. And then, as you've heard in the news, lots of research ongoing. There have been things that we thought would work that really haven't. There are some things that I know that are being studied now that I think are going to be really helpful. But for the public to know, you know, kind of the main things I would say is that the majority of people have mild to moderate cases that don't need hospitalization, so still no treatments that we know work there. And there definitely, we have not found anything that we would consider a cure for coronavirus.
All right, great information, Dr. Luke. We had a question come in, for Dr. Jamal. This is from Sean Conti. Thank you for your question, Sean. He wanted to know, Dr. Jamal, can you cite any research to support the contention that it is now more infectious but less lethal? And if there is something you could share, we could also leave that in the comments for everyone to take a look at afterwards. But Dr. Jamal, is there anything out there that kind of says that?
Yeah, I'll do a literature search, and you know what, I'll get that to you. This is again, as I said, it's conjecture. I think it was one article I read about how the virus had mutated, and how it's somewhat different. But I could find that for you.
All right, great. And as soon as we get that information, we will definitely put it in the comments section so everyone watching can go back and take a look at that as well. Over the last few weeks, there have been lots and lots of talks of vaccines being available. People are saying that vaccines might be available before the end of the year for most Americans. Generally speaking, I just want to hear from our physicians, what can we expect from a vaccine? I think sometimes people may not have a really good grip on how vaccines really work or how they're produced and what it takes to make sure you know that a vaccine is effective before it's made available to the public. So, Dr. Jamal, can you just give us a little bit of background about vaccines?
Yeah, so, you know, I want to give you a little bit of a big picture view of vaccines. I think that, you know, for the health of humankind, very few things have helped humankind more than separating our drinking water from our toilet water, from washing hands. And I'd say the third thing is vaccines. It's been that important in fighting the scourges of our society for millennia. So, you know, I'm hopeful that what we're doing and with the search for vaccines is gonna come to some fruition. So what vaccines are, there's basically two types of immunity you can develop, or you can help a patient. One is with passive immunity, where you get the antibodies against, say, a virus, and you give those antibodies to someone, and that we're doing with patients with convalescent sera, and in fact the new drugs that have been released, or that is still experimental, I should say, that Regeneron has, which is monoclonal antibodies to the virus. So that's passive immunity. What we're talking about with vaccinations is active immunity, and so what we do is we give a part of that virus. Usually, we try to make sure that that part of that virus, which in this case, in all the cases, has to do with this S protein, which is the spike on COVID-19, that we give that epitope is what it's called, in a vector that then causes your body to develop an immune response to it. And we're hoping that immune response, those antibodies, will neutralize the bacteria, the virus rather, that when you get infected. So it's that we're wanting that neutralization, and the concern is that with that you may get a very exuberant response, and are there side effects related to it? But you know, that's what these vaccine trials are now trying to determine. We have got four of the vaccines that are candidates that are in phase 3 trials, and yeah, and so you know, we're all waiting really with bated breath to see what's going to come of them.
Right. And Dr. Luke, I just want to, as physicians and scientists, when people think about getting a vaccine, is it something that's just like a snap of the finger, like once millions of people get the vaccine, then we can go back to normal and we can fly all over the place and we can stand around each other and go to large sporting events. Will it work that quickly, or does the vaccine need to go through like a process for us to like be able to get back to normal and know that, okay, it should be safe to do those things again?
Yeah, I mean, I think everyone on this call and probably everyone watching, right? Like we all want to go back to normal, and everyone wishes there was kind of that snap of the finger answer to this. And there really is just not. So I think the vaccine, we're all really hopeful. I certainly will be first in line once our scientific community says, yes, this has gone through appropriate testing. I'll be first in line to, to get it. And I'm very thankful for all the people that are participating in these phase 3 trials. Again, really heroes that are helping us get through this pandemic. But it's going to take some time. And, you can think of it kind of, it won't be exactly the same, but like with a flu vaccine. So everyone should get that. That's going to lower your chances, but it's not going to magically make it where everyone's immune or we can rush back in. So some conjecture on my part is I think it'll be kind of a ramping up, right? We'll ramp up the number of people that get the vaccine, and that will allow us to ramp back in, to the normal lives that we had, prior to March.
All right, great information. All right, and that will actually do it for our FWMD live chat today. I want to thank everyone on Facebook for being a part of today's live chat and leaving your questions. And also I want to give a special thanks to our guests, Dr. Luke and Dr. Jamal. Thank you so much.
Thanks, Prescott.
Thank you. Thank you.
All right. Now, what I do want to do is make sure that I let everyone know, if you go to the video section of our Facebook page, you can see our second-year medical student, Sarah Lyon, talking about the School of Medicine's voting guide initiative ahead of the November 3rd election. Big day, the presidential election will be happening, and also other smaller seats that need to be seated as well. So we'll put a link to a story on our website in the comment section. It has more information about that voting guide initiative that was put together by the School of Medicine Student Senate. And I just want everybody to remember that early voting begins in Texas on October 13th, and it ends on October 30th. And if you vote anytime during that period or on November 3rd, if you take a photo of your I voted sticker, be sure to share it with us on social media using the hashtag SOM_votes. That's SOM votes. And we will compile them and share them. And we just want everyone to go out and participate and use your voice in this upcoming election. So make sure you remember hashtag SOM_votes. That'll do it for today's live chat. And once again, everyone, thank you for watching. Thank you for being a part of this conversation. And we will see you soon.